Welcome, everyone. It's a pleasure to see so many of you at our Wednesday seminar today. And today you're in for a special treat. Our seminar today is co-hosted by the Division of Cardiology and the School of Medicine and by our Department of Population, Family, and Reproductive Health here in the School of Public Health. And I'm really delighted to turn over our talk today initially to my colleague in cardiology, Dr. Erin Mikos, who has the delight of introducing our incredible speaker for today. So Erin, I'll hand it over to you.
Great, thank you. It's my great pleasure to introduce a friend, a colleague, a collaborator, Dr. Sadiya Khan, who comes to us virtually from Chicago. She is a cardiologist at Northwestern Medicine and assistant professor in the departments of medicine and preventive medicine at Northwestern University Feinberg School of Medicine. She is the associate director of the Heart Failure with Preserved Ejection Fraction program and the director of research for the section of heart failure. Dr. Khan's clinical expertise is in the prevention and management of heart failure, women's cardiovascular health, focusing on maternal health, cardiovascular genetics. Her research focus on epidemiology, risk prediction, and mechanism of cardiovascular health across the lifespan, with a focus on the peripartum period. Dr. Khan has been continuously funded by grants from the American Heart Association and the National Institute of Health since 2015. And she's published over 150 peer-reviewed articles in leading medical journals, and her work's been cited over 6,500 times, which is really impressive because she's early in her career, so that's a lot already. She's an associate editor at JAMA Cardiology and serves as the vice chair of the American Heart Association Epidemiology Publication Committee. She's a recipient of the American Heart Association Women in Cardiology Award for Excellence, the American Heart Association Samuel Levine Young Investigator Award, and the Northwestern University Jameson Research Award. And so welcome, Dr. Khan, and she's going to be talking about maternal health and implications for cardiovascular health.
Oh, thank you so much, Dr. Mikos, for that kind introduction, and to both you and Dr. Minkovitz for inviting me to speak today, and to all for joining. I'm going to go ahead and share here. So the title of the talk today, and when Dr. Minkovitz and Dr. Mikos told me about this shared seminar, I wanted to try to link this focus on peripartum cardiovascular health with a life course approach, and made the title thinking about CV risk early in the life course, optimizing CVH pre-pregnancy. My disclosures. So the objectives for today, and I'll try to keep it to the time so that we have time for discussion and questions, are to look at an overview of the reproductive life course, so actually subsetting the overall life course to a time period when there are dynamic changes happening to cardiovascular health, define the epidemiology of maternal morbidity and mortality, and identify pre-pregnancy as a critical life period for promotion of CVH within the context of the reproductive life course, and conclude by discussing key knowledge gaps in the promotion of cardiovascular health during this period. So if we're to look at the schematic of the overall life course from birth to older adulthood and death, we know that specifically the reproductive life course of birthing individuals is marked by menarche, repeated pregnancies, and menopause. And during this time, dynamic transitions are occurring that can be associated with changes in cardiovascular health, although it's unclear whether these are causal, but what is observed is that significant changes are happening in terms of health behaviors, health factors, and risk for cardiovascular disease. Particularly, time periods around pregnancy, pre-pregnancy, during pregnancy, and postpartum are marked by specific events that can occur that may affect cardiovascular risk in the long term, both for the birthing parent as well as offspring. Specifically, in the pregnancy and postpartum period, emerging interest, and we'll talk about the epidemiology, is coming to light specifically around short-term maternal morbidity and mortality, particularly as we start to see increases in these and significant disparities that have persisted. With that, there's emerging evidence that these are not distinct periods, but these are related, that events that occur during this pregnancy and peripartum period, such as adverse pregnancy outcomes, are associated with long-term maternal morbidity and mortality and cardiovascular disease, as well as the health of the offspring from that intra-utero environment exposure. This is an example, but we know that there's a lot of data that adverse pregnancy outcomes are associated with risk of cardiovascular disease for the offspring. So shown here are data from a large Swedish cohort that looked at the relationship between being born preterm and risk of ischemic heart disease in the offspring. And what you can see is that overall in aggregate, for those who attained an age between 18 to 43 years and had follow-up data, there was a 55% greater risk, and when adjusted, 45% greater risk after being born preterm. And I think for most of us, that feels established in the literature in terms of outcomes related to preterm birth. What I think is more interesting is this figure that from the same group looking at the cohort and looking at maternal follow-up and the relationship between having a preterm delivery and ischemic heart disease. And what is really nice because this was such a large sample of individuals in a national cohort that was followed for decades, is we can see this graded response between a delivery that was term versus early term, late preterm, very preterm, or extremely preterm, and the risk of ischemic heart disease. So with this example for preterm, although it's similar findings have been shown for other adverse pregnancy outcomes, we can see the effect on both the offspring and the birthing parent. So where are we in terms of epidemiology of maternal morbidity and mortality? So what's the landscape of the problem? Shown here are absolute counts for several metrics of maternal morbidity and mortality. In 2019, nearly 300,000 live births were complicated by gestational hypertension and preeclampsia combined. 52,000 events that constituted maternal morbidity, 10,000 cases of eclampsia, 67 admissions to the ICU, and about 1,800 pregnancy-related deaths, whether directly or indirectly, were counted. These figures are, I'm sure, not new to anyone here in terms of the drastic difference between the US and other high-income countries, where there's not only a wide gap, but that is widening over time. In addition, on the right panel, this idea that the timing and the causes of pregnancy-related postpartum deaths are also unique. And what I draw your attention to is especially this later period, the 43 to 365 days postpartum, where the majority of deaths are related to cardiovascular causes, and of great interest, especially if there's changes with insurance or other social factors that may prevent or preclude care. In aggregate, all of the postpartum deaths, nearly 2/3, are preventable, which leads us to start to think what is happening during pregnancy or prior to pregnancy that may be leading up to this. If we look at trends in adverse pregnancy outcomes, and shown here are patterns for hypertensive disorders of pregnancy and preterm delivery, unfortunately, we see very similar patterns. Hypertensive disorders have doubled over the time period shown here between 2007 and 2019. And preterm delivery, which while was decreasing and was stagnant for some time, is now reversed and increasing. And what's interesting, a lot of this increase is driven by co-occurring hypertensive disorder and preterm delivery. In these national data from birth certificate registration, what we also see is based on self-report, non-Hispanic Black individuals have a much higher rate of hypertensive disorders and preterm delivery, and those disparities have not narrowed over time. We look at patterns for gestational diabetes, we see similar patterns, although the disparities are greatest for Asian individuals. And what is shown on the right panel here is actually the breakdown of the subgroups of Asian individuals with the highest rate of gestational diabetes among Asian Indians. And one of the advantages of the birth certificate data is that these data include self-report of disaggregated Asian and Hispanic individuals. So you can really get a better sense of the heterogeneity that's occurring in some of these racial and ethnic subgroups, to have a better sense of where different pathophysiology may be playing a role, as well as social factors that may be contributing. So I've shown you a pattern of increasing trends for maternal morbidity, mortality, adverse pregnancy outcomes. Where could that be coming from? One question that often comes up is this related to the age distribution of live births? And shown in this diagram is the overall distribution between 2007 and 2019 in each age group. And what you can see is while overall teen pregnancies have declined significantly, and the proportion of births that are happening between 20 to 34 are slightly smaller, it hasn't changed significantly over this period. And in fact, if you look at the age distribution of live births that are complicated by gestational hypertension, what I'll point out is that more than 50% are actually occurring in individuals 25 to 34. So age is not the driving factor that we see here. And if we look at this a different way, if we plot maternal age against adverse pregnancy outcomes for non-Hispanic white pregnant persons and non-Hispanic Black pregnant persons, what you can see is that there's just been a consistent shift upward from 2014 shown in blue to 2019 in red. For any given age, there's a higher rate of adverse pregnancy outcomes occurring. And in this aggregate, this includes hypertensive disorders of pregnancy, such as gestational hypertension, preeclampsia, preterm birth, and small for gestational age. So I've convinced you that I hope that there's a growing problem of short-term maternal morbidity and mortality, and this is occurring during the pregnancy period, then thinking upstream of what may be contributing to this is really important. And this is where kind of the focus of thinking about preconception health, and particularly preconception cardiovascular health, may be important as we see these changing and unfavorable trends. So if we look at the pre-pregnancy period in cardiovascular health, I'll start by defining the concept or the construct of cardiovascular health, which I'm sure everyone here is very familiar with, that was developed in 2010 by the American Heart Association as part of their strategic impact goal planning to shift the conversation from disease prevention to one of health promotion. And at the time, the construct included these 7 components: exercise, diet, body mass index, blood pressure, cholesterol, glucose, and smoking status. Shown here is a table of how these were scored and integrated. And while the details aren't as important as what I think is really interesting is the shift between just saying that somebody had a disease or didn't. So diabetes, yes, no. What you can see for glucose is that there's 3 categories: poor, intermediate, or ideal. And so even in someone who is well treated with diabetes, they can't ever achieve ideal health. And so this is the beginning of that first concept of, if we want to promote health, it's preventing disease or starting to get to that point where we're preventing the risk factor from occurring. So what have we seen in the last decade? There have been an abundant number of publications, including much work by Dr. Mikos and other colleagues here as well, that have shown the relationship between cardiovascular health, and specifically this construct, and a number of cardiovascular and non-cardiovascular outcomes in non-pregnant populations. And this is just a representative example of all of the different outcomes that have been studied and have really helped to solidify the idea that cardiovascular health is an incredibly important surrogate marker, and one that is important to target. So what do we know about how cardiovascular health changes? This was a really interesting study done by one of my colleagues, Dr. Allen, who asked the question: we know a lot about midlife cardiovascular health, but how do people get there? We know that cardiovascular health declines as you get older. And so what these colleagues did was they pulled data from Finland and the US, and over 9,000 individuals from the age of 8 to 55, and looked at trajectories. So kind of data agnostic, what kind of patterns come up if we look at different groups of cardiovascular health trajectories. And what they saw was that these patterns showed that it's very interesting that even though there's some difference already in early childhood, which I think is important, that by age 8, you can already see where people may be starting out, a lot of the decline and the changes in cardiovascular health happen during the reproductive years, which particularly for birthing individuals may be related to pregnancy. And that these patterns, especially the ones with greater decline, so the high rapid decline pattern in particular, as well as the intermediate rapid decline, had greater odds of having high carotid IMT or having greater carotid IMT by midlife as a surrogate for risk for cardiovascular disease. What if we move earlier in the life course and focus there? So this was an interesting study that looked at the National Growth and Health Study and followed about 2,400 specifically girls who were assessed annually between the ages of 9 and 19. This is a slightly older study. It was done in the 1980s, but they assessed cardiovascular health using the 14-point construct and looked at patterns. And overall, I think the patterns look very similar to the prior figure, although the spread is not quite as wide here because we're dealing with younger individuals, where we see that there's significant variation that's already happened by age 9. And we see some patterns of greater decline or faster decline in some individuals and stability in other individuals. One of the factors that they identified with that was associated with a higher odds of having cardiovascular health decline over this adolescence to early adulthood period was teenage pregnancy. They weren't able to identify whether adverse pregnancy outcomes particularly related to this, but it starts to tell the story that pregnancy is a time when cardiovascular health changes quite significantly, whether that's going into pregnancy with poor cardiovascular health or coming out of pregnancy with poor cardiovascular health. What do we know about pre-pregnancy cardiovascular health in the United States? Well, we use this the data from the birth certificates in the United States, which captures all live births. And we looked at pre-pregnancy body mass index that was self-reported and stratified by categories for underweight, normal weight, overweight, and obese, looking at those who self-report as non-Hispanic white, non-Hispanic Black, Hispanic, and Asian. And one of the things that was notable in all of these figures is that overall there's a decline in the number of pregnant individuals entering pregnancy reporting a normal BMI. There may be issues with underreporting for obesity, but overall the patterns seem to emphasize that we're seeing a decline in normal BMI entering pregnancy. And these are young individuals with an average age of 25. So really remarkable that even at this point, less than half of people have a normal BMI. We wanted to look at other risk factors in this data set. And so we looked at pre-pregnancy hypertension as well over the same time period between 2007 and 2018, stratified by different age groups from 15 to 44, shown here on the x-axis, and looked at the prevalence per 1,000 live births. We were particularly interested in regional differences and looked at rural versus urban differences. And what you can see is while there's differences across the age groups, these start to widen in older age groups, and there's much higher risk of entering pregnancy with hypertension in older age groups, which isn't a surprise to anybody. Overall, we saw significant differences by self-report of race and ethnicity, with non-Hispanic Black individuals having higher rates of pre-pregnancy hypertension. Even within those individuals who self-reported as non-Hispanic Black, rural individuals had higher risk of pre-pregnancy hypertension than urban individuals. And why is this important? Hypertension is a leading risk factor for maternal morbidity. And again, in a very young population, we're seeing increases over a very short time period. So to summarize, we have increasing rates of obesity and severe obesity in this young adult period, pre-pregnancy or peripartum, higher rates of hypertension, and higher rates of prediabetes and diabetes as well, which have been demonstrated. So potentially there's almost a kind of coming together of both pre-pregnancy risk and pregnancy-related risk that is leading to this increasing burden of maternal morbidity and mortality based on these increasing prevalence of risk factors in this population. So what do we know about cardiovascular health in pregnant populations? Shown here is a distribution of cardiovascular health in pregnant persons that comes from the NHANES survey from 1999 to 2011. And what you can see is that a majority of people fall in the low to moderate category, and very few pregnant individuals are in the high category. And what does this mean in terms of maternal and offspring outcomes? Going back to the birth certificate data, we also were able to characterize clinical cardiovascular health coming into pregnancy, specifically using the BMI report, hypertension, diabetes, and smoking status. And what we saw were those individuals who were entering pregnancy with poor cardiovascular health scores, so lower being worse, had a much higher risk of having any one of these outcomes: maternal ICU admission, preterm delivery, a low birth weight infant, or fetal death as well prior to 20 weeks. And the relationship was graded and consistent across all of these outcomes. We know that there are significant disparities in the risk factors that comprise cardiovascular health, as well as the composite of cardiovascular health. And these were data where we looked by health insurance provider as well as WIC status. And I think it's specifically taking a step back in the overall pregnant population in the US, 50% of pregnant persons are enrolled in Medicaid for their delivery, and 30% are enrolled in WIC, and that doesn't include many more who may be eligible and not enrolled. And looking at the disparity between those who are receiving Medicaid or who are receiving assistance from WIC in pre-pregnancy cardiovascular health starts to tell the story of why we may be seeing adverse outcomes related to pregnancy or higher rates of severe maternal morbidity and mortality in these individuals. We also know that there are significant geographic disparities in pre-pregnancy cardiovascular health. These are data from the birth registration data set where we quantified for each state what the prevalence of being in ideal cardiometabolic health, so having a normal BMI, no hypertension, and no pregnancy, and no diabetes. And you can see that the areas in green or darker green are the areas that have a higher proportion of individuals who are pregnant who have optimal cardiovascular health coming into pregnancy. And in the red shaded areas are those that have a lower prevalence. And specifically in the South, where we often see very similar patterns, if we're looking at a map for cardiovascular disease risk, we see a lower proportion of birthing individuals coming into pregnancy with optimal cardiovascular health or without a cardiovascular risk factor. We saw that these patterns were similar over a short time period, but we were starting to see more states entering that lower prevalence of pre-pregnancy cardiovascular health status. And the kind of aggregate data in terms of the geographic disparities as well as social factors really leads back to the fact that we know that these upstream social factors are clear targets for cardiovascular health in this young adult pregnant population, as well as prior to pregnancy and following pregnancy. And the physical environment and social and economic factors that play a role in overall health in this figure that was adapted from the county health rankings are really important things to consider as we think about fundamental causes of health inequity and structural and systemic racism that are playing a key role, particularly at the neighborhood level and at the individual level. So I've talked a little bit about where the burden of disease is, potentially the role of cardiovascular health in these populations and in the risk that we're seeing. But what about the promotion of cardiovascular health, and particularly in the pre-pregnancy period, as a potential window of opportunity? So the American Heart Association, the American College of Cardiology, and the American College of Obstetrics and Gynecology have all highlighted the reproductive years as an important life period to focus cardiovascular risk identification and reduction. And there have been several statements and many more, in addition to the two highlighted here, that really help to focus on the primary prevention of cardiovascular disease and promotion of risk identification and reduction in this reproductive period. A lot of the work that we've seen has also focused on maternal morbidity and mortality, which really, I think, one of the things that we're seeing as we flip the narrative from disease to health is that it's really just the tip of the iceberg. And looking below the surface as we start to consider health and cardiovascular health as a target, moving away from this disease state perspective will be important, as well as tailoring prevention approaches, focusing on the pre-pregnancy period when interventions may be the most effective, especially if leading into pregnancy, interventions may be able to help prevent the adverse pregnancy outcome that we know is then related to downstream sequelae. And lastly, elucidating mechanisms related to peripartum cardiovascular health and intergenerational transmission as we think about the cyclical nature of how birthing parents, offspring, and future generations experience risk. So if we think about the pre-pregnancy cardiovascular health and adverse pregnancy outcome schematic seen here, we know that the placenta is a key place where a lot of this mechanistically is happening that is contributing to risk for adverse pregnancy outcomes. In this diagram, you can see the various factors that contribute to the potential risk for ischemic placental disease, including genetic risk factors, environmental factors, the risk factors related to cardiovascular health that we spoke about, as well as oxidative stress, innate immune dysfunction, and other inflammatory pathways that lead to this overall activation of inflammatory markers such as sFlt1 or soluble endothelin and other markers that we know are associated with later life cardiovascular disease risk as well. There's overlap in the mechanisms and markers that lead to abnormal placentation that suggests that potentially some of the risk that's occurring is occurring before pregnancy, given that the placenta is one of the earliest signs of development of pregnancy. And so what are the other factors that may be contributing to abnormal placentation that then lead on to preeclampsia and other adverse pregnancy outcomes and future cardiovascular risk? This is data from the UK Biobank in this really nice paper from Dr. Honigberg and colleagues that looked at genetic risk markers for cardiometabolic traits and looked at the association between these markers or polygenic risk scores for each of these traits shown here and the odds of developing hypertensive disorders of pregnancy in the UK Biobank, where they had a sample of over 200,000 women who had filled out questionnaires and surveys about prior pregnancies. In that sample, about 1.5% reported having a hypertensive disorder of pregnancy. And in those who reported a hypertensive disorder of pregnancy, the blood pressure at the time of the visit was about 10 points higher. The systolic blood pressure, and the diastolic blood pressure was about 5 points higher. When they applied the polygenic risk score, what they saw was that individuals who had a genetic predisposition for having higher blood pressure as characterized by the polygenic risk score or diastolic blood pressure had a 20% higher odds of developing hypertensive or having developed hypertensive disorder of pregnancy that they had self-reported in the past. They saw a similar relationship with BMI, although slightly weaker, and no relationship with diabetes. It suggests that this may be a causal pathway of early life or pre-pregnancy cardiovascular health as a target prior to the development of adverse pregnancy outcomes. A lot of what we've talked about and identified is that there's significant risk for adverse pregnancy outcomes related to pre-pregnancy or early pregnancy cardiovascular health. There may be genetic risk markers that identify individuals who are at risk for having a pregnancy that's complicated by gestational hypertension or gestational diabetes. But one of the questions that I think is of great interest is an adverse pregnancy outcome just a marker of pre-pregnancy cardiovascular health? Just reflects the latent environment that was already present, and pregnancy was the stressor that helped identify this risk factor? Or is it really a mediator? And is there an additive role of the injury related to preeclampsia or hypertensive disorder with later life cardiovascular disease? And I think this is one of the key questions that remains in the literature, where we've seen a lot of epidemiologic associations between adverse pregnancy outcomes and later life cardiovascular disease. And we know that individuals who experience the adverse pregnancy outcome are identified to be at higher risk for later life cardiovascular disease and may benefit from intensive interventions. But mechanistically, is it on the pathway or has an additive role? And I think that's a really interesting question that may help inform how we approach and intervene on risk. One of the things that we're working on to help try to identify this is an ancillary study in the New Mom to Be Heart Health Study, which is a study of about 10,000 nulliparous individuals that were recruited during their first pregnancy back in 2010. And at that time, the first visit occurred before 14 weeks gestational age. And we have measures of cardiovascular clinical risk factors, as well as health behaviors to assess cardiovascular health early in pregnancy. Since then, the individuals have been followed for the completion of their first or index pregnancy and have had a follow-up visit at 2 to 7 years and are now coming back for a follow-up exam about 10 years later. We have chart abstraction and adjudication of all recurrent pregnancies, and as part of one of our ancillary studies will be performing carotid IMT and proteomics using the SomaScan platform to try to start to address some of these mechanistic and pathway questions for the relationship between adverse pregnancy outcomes and subclinical cardiovascular disease later in life. As we think about pre-pregnancy, I think the question always comes up that pre-pregnancy for one pregnancy, maybe postpartum from another pregnancy. And on average, individuals may have more than one pregnancy, and using that inter-pregnancy or initial postpartum period as a key period for cardiovascular health promotion and understanding mechanisms. Pregnancy can be sometimes difficult to study, and I'm curious, and hopefully we'll be able to have some discussion around how do we approach and adjust for the influence of prior pregnancies on future pregnancies when we know these are related events, particularly around preeclampsia, preterm delivery, that having had a pregnancy with one of those complications, that it's much more likely that a follow-up pregnancy may have that, or even just the bias that comes with if there's a severely complicated pregnancy, there's bias in the potential that someone may not get pregnant again. And so in epidemiologic or observational data, there are biases in who may have a follow-up pregnancy. Regardless, I think one of the important things around this interpregnancy or interconception period is we can really target or identify individuals that have had a complicated pregnancy or adverse pregnancy experience that may make it more, that may warrant more intensive prevention strategies. And this was a really nice paper that was published in JAMA Cardiology just a few weeks ago that looked at this idea of identifying interventions, particularly for individuals who have had adverse pregnancy outcomes. And the diagram or schematic shown here was one suggestion was around transitional care clinics. So in anybody who had had a delivery complicated by an APO to be referred to one of these transitional care clinics that can help in that first postpartum period in the first 6 months for education, counseling, screening and risk assessment, medication management, and that transition to primary care, because we know a lot of the healthcare gap that may come is in loss or transitions in loss to follow-up, particularly in those who are high risk, who may warrant specialty care, preventive cardiology consultations, whose blood pressure has not gotten under control, given the high risk of developing cardiovascular risk factors and cardiovascular disease, particularly in those first 5 to 10 years after an adverse pregnancy outcome. Shifting gears over to kind of the offspring side of this, the intergenerational transmission of cardiovascular health is something that's also of great interest when we think about the uterine environment and complications of adverse pregnancy outcomes. So if we think that maternal cardiovascular health informs adverse pregnancy outcome risk and future offspring cardiovascular disease risk. This was a really nice paper from Dr. Perrick and looking at the HAPO study, which is an international cohort of about 2,000 mother-child dyads that have now been followed for about 15 years. And what they did was they looked at the cardiovascular health categories shown on the x-axis here for the birthing parent, and categorized individuals as having all ideal metrics, intermediate as greater than or equal to 1 intermediate, but 0 poor metrics, 1 poor metric, or greater than or equal to 2 poor metrics, and cross-tab that with the offspring cardiovascular health in adolescents, and looked at the odds of developing poor cardiovascular health in the offspring if the birthing parent had poor cardiovascular health, and the odds of having ideal metrics. And I think it's really striking. What we see is that the potential of having ideal cardiovascular health in the offspring is driven remarkably by maternal cardiovascular health during that pregnancy. We think broadly about the concept of ideal cardiovascular health, the categorization between optimal, intermediate, and having risk factor that's at the threshold of treatment. One other way this might be useful is in the clinical translation of how we can think about this intermediate group as a window of opportunity. Oftentimes, we see people that have hit the threshold for treatment, whether it's an A1C or a blood pressure value, and that may be 140 or 130, depending on their risk target. and everybody else is grouped together in terms of what our management may be. Obviously, everyone needs to follow a heart healthy lifestyle and promotion, but if we target those individuals who are in that pre-stage, and for diabetes, this happens perhaps more because of the categorization of prediabetes, but really identifying this group coming into pregnancy may be a way to help focus more intensive prevention measures, even in the absence of treatment thresholds for disease. So I'll kind of summarize with putting that kind of concept together is, instead of trying to improve cardiovascular health once it's lost, and the idea that perhaps we can't really go backwards once cardiovascular health is lost or a risk factor has developed, can't go back to attain the optimal or ideal state. Why not preserve it? And this is in reference to Dr. Mikos was mentioning earlier as we were chatting, the presidential address that Dr. Lloyd Jones gave at American Heart Association Scientific Sessions this year, focusing on the idea of primordial prevention being added to our pyramid of primary, secondary, and tertiary, where we spend a lot of our clinical time, as really launching the foundation for cardiovascular health. In order to prioritize and promote cardiovascular health, we need to begin with and maintain it rather than try to return to it. And this was the accompanying statement in circulation that reiterated that focus on primordial prevention. And part of the narrative that was outlined here was that we have come a long way in the last several decades. We have incredible advances in terms of therapeutics for lipid lowering, novel therapies for heart failure, devices for cardiovascular disease, but the overall health of our nation is actually declining. And a lot of the data that we saw today shows that as well. And we focused on pre-pregnancy for individuals who were having children, but that's not really unique to that population. It's something that we're seeing across generations and across age groups. And so thinking about how we may want to refocus some of the preventive efforts to identify earlier in the life course, perhaps even as early as in utero, and identifying those individuals that need more focused interventions for prevention. So I'll summarize by 3 key takeaways. A shift in focus from maternal morbidity, a disease state, to maternal health is needed, and very analogous to what we've done for cardiovascular disease to cardiovascular health. Focusing on opportunities for equitable promotion of cardiovascular health in the pre-pregnancy period for maternal and offspring outcomes, knowing that there are many social determinants of health that influence early life cardiovascular health, that cardiovascular health trajectories are variable and already differentiated by early childhood as early as age 8. And that this reproductive life course framework requires elucidation of upstream risk, so focusing in this pre-pregnancy or early pregnancy cardiovascular health, downstream risk of disease, and underlying mechanisms as well. Thank you so much for your time and attention, and looking forward to the discussion and any questions.
Great. Thank you. That was absolutely outstanding. I really, really enjoyed your talk, and it was very comprehensive, and hopefully people can put some questions in the chat bar. So I open up my chat bar, but yeah, I guess the big challenge is, the implementation piece. I think that a lot of this doesn't come as surprising, that we need to improve the population health, starting in utero and through. There's been a lot of attention to the growing problem of obesity and diabetes in youth and adolescents. But the real question is, how can we shift this needle? And I think this is really going to be taking, policy change. And it's beyond, I think, just the individual. We always tell people that they need to eat better and exercise more. But, that is fine. But these are, so much of this is driven by social determinants of health and barriers, and is really going to take, policy and other initiatives. So I don't know where you think the field may be going in terms of, implementation a piece about how to improve the cardiovascular health in this population.
Yeah, so of course you asked a tough question that I was trying to avoid by focusing on all of the problems rather than identifying solutions. Now, I think that's a really important question, and the place that we're all probably grappling with is describing and defining the problems are very clear, but how do we actually implement strategies that will be effective, and also how do we personalize those strategies that may be different across different populations? And I see Anne on the line, and I think we met a few months ago when we were preparing our enriched populations. So it's so nice to see you. But I think that's one really great way is partnering with home visiting programs and identifying organizations that are in place to support individuals during this period. And I think one of the really neat ways that NHLBI is doing this through this Enrich Consortium, which is really exciting, is trying to integrate into the resources that are already there to highlight cardiovascular health. And even more, I think that hopefully will help raise awareness. There are a lot of data around the low awareness, particularly in young adults and young women, that cardiovascular disease is even an important risk factor for them. And I think that's perhaps where some of this even needs to start, is how important and cumulative some of this risk is, right? I think many young people, which I probably can't count myself in that anymore, feel invincible and don't think that this is something you have to worry about later, right? Let's just get through whatever the current stressor is, and then the current pandemic even more so, right? And so I think it's bringing awareness and attention back to particularly that concept that you can't really re-achieve ideal cardiovascular health. We can get close, and we definitely want to get close and start to recover if there is loss, but you can't go back all the way.
Right.
So I sidestepped your question still.
I know, I don't know the answer to the question, but I'm glad you brought up the home visits. It's something that obviously to this group and this audience is very passionate about. And there was one comment, this is, I guess, a little bit more getting into the obstructive cardiac obstetrics field, but looking at, what can be done to screen or assess for preclinical signs of heart disease in pre-pregnant women, and are those methods cost-effective in application? So what can we do for screening before pregnancy?
Yeah, I think one of the things that's really impactful about the way cardiovascular health is identified or is created in terms of the construct is that it's a low-cost application. And it sounds so simple, but even that discussion of where someone falls in terms of their dietary behaviors, their physical activity, the blood pressure categories, and the additive nature of it, so that even if you're intermediate on several of them, you may end up in the same place as somebody that only has one risk factor. And so bringing that into the clinical space, and I know that's work that Dr. Lloyd-Jones, Dr. Allen, and a lot of other colleagues are really interested in, and is trying to connect that and using that as a framework for starting some of these individual level discussions, as well as, Aaron, as you mentioned, policy decisions that try to comprehensively cover. And so we're not just focused on just weight or just blood pressure or just one risk factor, but really thinking about it comprehensively.
Great. So there's another question about the association you presented between maternal gestational cardiovascular health and offspring's cardiovascular health. And so how much of this is due to shared genetic factors? How much is due to environmental factors in the same home? And how much is due to actually the risk conferred by the APO itself, the adverse pregnancy outcome itself on the fetus in utero?
Yeah, I think it's a great question. There's actually been some interesting work looking at the heritability of cardiovascular health that was led by Nori Allen. And what they found was actually that 15% of cardiovascular health was heritable. So the large majority is environment. And so I think that applies as well when you look at the relationships between maternal gestational health and offspring health as well. I think the idea that the in utero exposure in the offspring may have an additive role, so that perhaps not everyone is born with ideal cardiovascular health, particularly individuals who may be born preterm or who may have been exposed to higher glucose levels or higher blood pressures in utero as well.
Okay, great. So there's a long comment from Dr. Yin. You can read that in a minute. I wanted to get to this question about on the primordial prevention front. What efforts, so I guess this goes back to what I was trying to get at the beginning about policy, to onboard, bring food manufacturers on board, and what kind of regulation we can do to improve cardiovascular health through regulating some of the highly processed and foods that we have.
It seems really apparent, the one thing, if there was one thing that we could change in our food environment, it would be lowering sodium. And I think we're starting to see steps towards that with the FDA identifying that and trying to create initiatives and policies around lowering sodium in our food. And of course, it'll be, I think, a very difficult process, but more work, especially from, I think, our health economics colleagues and a lot of people that are interested in trying to model what we could see benefits for. It's really hard sometimes to try to convince, even health systems and thinking about on a level that is, you're not going to necessarily see the benefit, but speaking about the general benefit that as a country or as a health system that we may need from altering whether it's food source or providing resources. And some of the comments are also talking about adverse social factors and the different investment that we need in community engaged work to be able to change these patterns that we're seeing.
Great. Oh, Dr. Page, you have one comment? I think you're on mute. I think you're on mute, Dr. Page. Were you trying to speak?
I am, and
okay.
The gods were preventing it. A great lecture. I want to comment on your last point and then ask another question. Your data on the Medicaid and WIC is interesting. They're both showing a downtick in participation. Have you thought, or have you actually disaggregated the Medicaid and WIC and taken a look at, there's a fair percentage of WIC that's not on Medicaid and the vice versa. And there may be opportunities to be given to distinguish the nutritional impact versus the availability of medical care, prenatal services, and all of the attendant social issues associated therewith. But I also want to comment on the intergenerational issues and the issues of potential epigenetic considerations, but also the concepsus itself. And I was curious in terms of both scrubbing of the concepsus with regard to the epigenetic issues and whether in the final thought on the concepsus, whether male DNA can play any role in actually influencing or accelerating adverse risk. Thank you.
Thank you. So I'll answer the first question. I think that's a really interesting observation about kind of the discordance between WIC and Medicaid, just because we know Medicaid covers so many more births than individuals who are enrolled in WIC. And we haven't looked at that. And I think that's a really interesting question of what the difference might be. The challenge I would see in better understanding that is that we don't really know who's eligible for WIC, just whether or not someone signed up. But I think to your point, it's probably there's an underutilization as well. So identifying people that maybe are underutilizing. And I think some of the strategies that we've talked about as well before in terms of identifying resources and, whether it's a lay community worker or a healthcare navigator or a individual that can help connect people with resources probably would be very helpful in those types of circumstances with existing programs, in addition to enriching those programs.
Thank you.
To your second point, which I don't know that I have a good answer, but I think it's a really interesting point in terms of the epigenetic mechanisms that may help us better identify how the intergenerational transmission may be occurring, whether the in utero environment is contributing to these risks and how that may be happening. But I'm not sure about the male sex in terms of that.
Yes, thank you.
Great.
Thank you very much.
Thank you.
Dr. Minkovitz, do you have some comments to add? Yes.
So Sadiya, great, fantastic talk, and definitely a Lifecourse perspective, which resonates very well across our department. So I guess if you had your crystal ball, now that a lot of states are moving in the US to expand public insurance postpartum, although not as fast as we would like, do you think that ultimately that might lead to some improvements in early cardiovascular health, or at least delay progression?
Hate to sound pessimistic, but I think if it is partnered with the right education and awareness, because outside of insurance and having access to healthcare, I think we need to make sure that there's support in place for individuals to help prioritize their health. There's been some interesting suggestions in terms of pairing pediatric visits with maternal visits for blood pressure follow-up. I think home visiting is a great opportunity for trying to connect this, but oftentimes birthing parents start to ignore their own health, and that has some to do with insurance, but probably a lot more to do with broader social circumstances and time. But I think helping to prioritize and removing the barrier of healthcare will definitely be helpful. But I don't think alone it will be.
Sure. And I appreciate your calling out to generational strategies and home visiting in particular, as well as the enrich mechanism. So who knows, maybe we'll be a lot smarter in a few years. So here's hoping.
Hopefully so. Hopefully so.
Great. Well, there's a lot of good discussion in the chat. I think a lot of it's comments and things. I was trying to see if there's any other questions, but there's some great comments to read through what everyone has to say. Did anybody else have a comment or question? I know it's hard with the big gallery to see everybody if they have their hands raised, but no? Any final parting words, Cynthia?
Well,
Yes.
I guess I'll just ask one other question, if you don't mind. So, as you think about training that, cardiologists have and primary care clinicians have, or nurse practitioners and a whole variety of other folks who interact with either young adults, adolescents. There's a comment in the chat about, engaging adolescents and thinking about strategies. Do you think our training fundamentally needs to improve so that our workforce thinks differently about cardiovascular health promotion?
We definitely need to invest more in terms of what our workforce is learning from the health behavior standpoint, but also perhaps diversifying the workforce is part of this as well. Most of our health systems and our delivery processes are set up with the physician in the center, which is probably actually part of the problem. As a physician, I think I can say that, but really being able to diversify who's delivering that care. And we know that people can be very, very effective if they're focused and specified in one area. So I love preventive cardiology because then I know what I'm focusing on, but not everybody necessarily has, nor is it scalable to say that everybody needs to see a preventive cardiologist, nor should it be set up like that. But being able to have, I think, whether it's patient navigators, I think that's a really neat idea, community workers that are engaging, clinical pharmacists, being able to come up with different strategies for different health systems. But it takes health systems investing in that model, which I think is always the challenge.
Great, thanks.
Great. Well, unless there's any other last questions that I'm missing or something, I think we can close out this really fantastic lecture. I mean, I really always enjoy hearing from you. I always learn something new each time, beautiful slides. So this really resonates with what so many of us are working on. So really, really enjoyed that you took time out of your day from Chicago to come to visit us in Baltimore. Hopefully next time it'll be in person.
Absolutely. No, thank you guys so much, and really wonderful discussion. And thank you all. And it's incredible work that you're all doing. So I'm looking forward to hearing more and hoping to stay in touch with you all.
Thanks so much.
Thank you.
Take care.
Thank
Bye.
you.